So today is a lot about diabetes and a little bit about sickle cell. Fair enough? A lot about diabetes and a little bit about sickle cell. And this is chapter 20. Chapter 19 is a self-study chapter. It's about abdominal issues. It's of low priority on the registry. If we're dealing with abdominal issues, it's going to be in a trauma setting. So we'll address it in the trauma setting as far as where the organs are and what they're responsible for and stuff like that. You just don't get a lot of belly calls, and if you do, it's probably cardiovascular, like an aneurysm or something in the aorta. So we'll talk about it. Please read the chapter. I don't want to just say it's not important, because it is, but there are some EMT textbooks who don't even include abdominal emergencies. Appendicitis, pancreatitis, stomach ulcers, diverticulitis, Crohn's. Those are all chronic type diseases. So if you read the chapter, I think you'll be versed. Please bring questions tomorrow if that turns out that way. So there is a lot of endocrine emergencies you'll respond to, because what was the number one comorbidity factor? Diabetes. Specifically, which type? Type 2. If there's a type 2 that tells you there's a type 1, is there a type 3?
Yes.
What?
Alzheimer's and dementia.
They are saying that that's what that is now.
Insulin resistance in the brain.
Insulin resistance in the brain. Brain doesn't have its right fuel. Can't eat. Blah blah blah. And it turns out looking like some of these conditions that we know of. Basically, organic brain syndrome. So, yeah, the next time this is taught, or maybe when you're in my shoes teaching it, we've got a firm type 3 diabetes. So keep that in mind as we go through it as well. And then we'll talk about those other things. So what is the endocrine system? A little A&P review. Glands and hormones. Glands and hormones. Anybody tell me what the master gland is?
The pituitary or something like that.
The what? Try that again, Gus.
Pituitary.
Pituitary, there you go. I knew you'd get it. Good job. The pituitary gland is called the master gland. It's kind of like the thermostat on the wall. Thermostat senses something, it sends a signal to change the temperature in the room by activating different parts of the body or the air conditioning system. It does the same thing in your body. It senses something. What's those receptors that sense something? We had two big categories of receptors that sense things. Chemoreceptors and, oh, I like those. Chemoreceptors, baroreceptors, pressure. They report back to the brain via the pituitary, and then they signal different hormones. We have hormones that release other hormones. Follicle stimulating hormone goes and tells the ovaries to release a follicle. Thyroid stimulating hormone tells the thyroid to release more thyroid style hormones. It's a very intricate system. I think I've told you this. There's a book out there by Dr. Aziz, A-Z-I-Z. It's called The Perfect 10 Diet. It's not so much a diet book as it is balancing the top 10 hormones in the body. And the big takeaway from his book is if one hormone is out of balance, they're all out of balance. You can't disrupt one hormone. Just pick a hormone, get it out of balance, the other ones will be out of balance trying to compensate and make up, trying to return to homeostasis. This is why people struggle with weight loss so much, is the out of balance of hormones. I would venture to say, and I think I'm certain in saying it, there's not a cell in your body that's not affected by hormones. And the big broad category of me saying that is the metabolism. Every cell has to eat. And if it has to eat, then it has to be metabolized from the food source. And that's the role of what we're going to get into today. Okay, there you go. We've already talked about this. I remember being a new EMT, and I never thought would know so much about diabetic emergencies. So Gus, back to what you were saying, you're going to make calls on this all the time. Your cardiovascular calls, yes. Your respiratory calls, yes. This is right there in the top 3. Just so many people with it. And in their sample history, they may not say, hey, I have type 1 or type 2 diabetes. Do you have to be diagnosed with one of those to have a diabetic style emergency, a blood sugar issue? No, you can just be, pardon my language here a little bit, if you may, but there are people who go on what's called Operation Starvation Fat Ass. You know what that is? Yeah, they just wake up one day and they're so disgusted in the mirror, they just go on a starvation diet. Like, I've got to get this weight off. Nothing else has worked, but I know if I eat, I get big, so I'm going to stop eating. What happens to that person within a few hours, if not sooner? Yeah, the blood sugar bottoms, doesn't it? It bottoms out. Do you think they are prone to taking stimulants while they do that? Like load up on caffeine or load up on energy pills or phentermine. Phentermine is a form of amphetamine that people take to lose weight and it suppresses appetite. Yeah. And that's a very, very, very common call. And you find these people in public settings and they're very hesitant to tell you, actually what's going on. Do you take any medications? No. So what's happening here? And if they're awake enough to talk to you, you may have trouble even getting that out because of the vanity issues, and nobody wants to admit that that's the program that they're on and things like that. So you don't have to be diagnosed to have these issues. This is kind of a lie. And I didn't discover this lie until in the last 4 or 5 years, and it really pissed me off that we were so ingrained, if you will, or so pushed or focused that the brain can only eat glucose. Now, if it's got a choice, which one would you rather have? Glucose is easier to metabolize. It enters the cell readily. You like it. I'm pretty sure most of you like sugars, glucose, fructose, all those forms of sugars. The brain does too. It's easy to metabolize, but it's not the only thing the brain can eat. There is another fuel source for the brain called ketones, and it's a fuel source for everything. You can live with 0 carbs. You can't live with 0 fats. You can't live with 0 fats. This is going to be a lot of wives' tale breaking in this lecture as well. So when I say wives' tale, it's traditional, what we've been taught over the years. There's nothing wrong with carbs, don't get me wrong. But if that's all you're eating, and that's all a diabetic is eating, they get into these issues. And maybe by the end of this, you can understand why. But the brain needs glucose and oxygen. I will not deny that. But it can run on ketones. Now, ketones are a byproduct of fat metabolism. We'll get into that a little bit. We know what insulin does. Glucose cannot cross the cell membrane without the helper protein called insulin. It's called facilitated diffusion, Gus. I remember you bringing up diffusion and active transport. To facilitate something means it helps it. So for the glucose to get in the cell, it has to be facilitated, and insulin is that facilitator. Type 2 diabetic gets into an issue to where the cell fails to recognize its own insulin. And it says, that's not my insulin, so I'm not letting you into the cell. That's what happens in a type 2 diabetic. A type 1 diabetic just doesn't have any insulin. If you want to know what the big 2 differences are, type 1, no insulin. Type 2, the cells don't like the insulin that's available. They are insulin resistant. Have you heard that term before? Insulin resistance. Now, in the Oklahoma language, that means the cells are sick of seeing the insulin. You have worn out your welcome, so to speak. Why would that, how does that develop? Hunter, you want to take that? Why do the cells get so sick of their own insulin or the human's own insulin? If someone's at your house too much, you get annoyed, don't you? And when they come back, you make up some excuse of why you can't house them, why they can't visit. It's not a good time. That's basically what the cells are doing, because they see it too much. Because we spike our insulin, when I say we, general population, spikes their insulin so often, so repetitively, that the cells say, don't want it. So that's how a type 2 diabetic gets in trouble. Some people say a type 1 diabetic, you're born with it. Type 2, you make it happen. It's a lifestyle choice. So we'll get into that. Bottom line is there are no glucose molecules getting into the cell to cross into the mitochondria to produce ATP. So we're out of ATP. Is ATP and oxygen needed for anaerobic metabolism? If I don't have one of the two, we get into a weird type of metabolism, right? We talked about aerobic and anaerobic the other day. So we have to turn, the cell's still going to try to survive, and it turns to fats to do that. So we'll look at that in a minute. Where does it come from? It comes from the pancreas. Insulin is produced in the pancreas. Way out there on the tip of the pancreas, so if you had a picture of the pancreas, it's in the left upper quadrant. We divide the abdomen, draw a line through midline and across your umbilicus, and then divide it up into 4 quadrants. The pancreas is in the left upper quadrant, abbreviated LUQ. So here are the quadrants. Here's this pancreas out here, and out here on the end of the pancreas, what we call the tail, they call the tail of the pancreas are some specialized cells called the islets of Langerhans. It's on the screen up there. The islets of Langerhans. And these are just little jets, if you will. If you want to describe them as jets. They're just little holes that kick out a hormone. They kick the hormone out. If they kick the hormone into the bloodstream, it's called an endocrine gland or an endocrine hormone. If they kick the hormone out of the body, like your sweat glands do, it's called an exocrine gland. Exit, X for exit. There are glands in your stomach, and Regan and I were talking about the proton pump inhibitors and the proton pumps which secrete your stomach acid. They kick that acid outside the body, don't they? It's into the stomach, but we know that the stomach is outside the body. At least the contents of it. So that's an exocrine gland. Well, the islets of Langerhans are endocrine glands because they kick the hormone into the bloodstream. Your pancreas is both an endocrine gland and an exocrine gland. The main role of the pancreas is in digestion. This insulin production stuff, it's way out there on the tail of the pancreas. It's important, but the major, if you look at it volume-wise, is a hormone called pepsin, P-E-P-S-I-N. And the pancreas kicks pepsin over into the small intestine to aid in digestion, help break down the food. This is actually where Pepsi, the soft drink Pepsi, got its name. The original pharmacist who developed the formula for Pepsi touted it as aiding in your digestion. Just like Dr. Pepper had a medical reason for invention of Dr. Pepper, and you were supposed to drink it at 10, 2, and 4. That's why the logo for Dr. Pepper is 10, 2, and 4. It was prescribed to you to drink it at 10 o'clock in the morning, 2 o'clock in the afternoon, and 4 o'clock in the afternoon. Coca-Cola was the same way. All these soft drinks were invented by pharmacists. And when you went to buy a soft drink, it was a big deal. You took a date to get a soda, it was like going to a concert. It was a big deal. They were very expensive and you had to go to one place to get them. So they were very limited. You didn't drink a lot of them. And now we drink them what? It's cheaper than water. Go to Walmart and look at 2 liters of water and 2 liters of Coca-Cola. Oftentimes the Coca-Cola is cheaper. Alpha and beta cells in the islets of Langerhans. The alpha cells produce glucagon. Is that a hormone? Beta cells produce insulin. Is that a hormone? Are they complementary or are they contradictory? Who said contradictory? Why? Why do they contradict each other?
Because one produces glucagon and the other one produces...
Okay, but the hormones themselves. Let's do a compare and contrast to insulin and glucagon. Anyone?
One's the mechanism, one's the release.
Good try. Thank you for trying. I love an effort. They're contradictory. What one does, the other one does the opposite of. Insulin has one job. It's only got one job. Glucolytic. So what's the word lytic mean? L-Y-T-I-C? Get rid of. Gluco means sugar. So insulin is a glucolytic. Means it does what? It gets rid of sugar. That's its entire goal, is to get rid of sugar. Where does it offer the sugar first? Who does it offer it to first? The cells. Insulin goes and binds to the sugar and carries it to the prom, if you will, and says, do you want this? If the cell needs fuel, it will say, yes, come on in. What if the cell is satisfied? It starts the process of storing it. So the next step in the storage process is, let me get 3 of you together and I'll make a triglyceride. Now that is a very Oklahoma, Bryan County, Colbert kind of way of saying it, okay? So bear with me. But it's not false. Let me get 3 of you together and form something called a triglyceride. You ever heard of triglycerides? You did a homework assignment called Study Metabolic Syndrome. All right? Remember when I told you to look up metabolic syndrome?
Right.
Maybe. Who looked up metabolic syndrome? Luke. Luke's like, why did I raise my damn hand? Remember metabolic syndrome? High blood, mildly high blood pressure, BMI is getting out of range, abdominal fat. You remember all that? And one of them was hypercholesterolemia, too much blood cholesterol, and also too many triglycerides. Too many triglycerides. That's because the insulin got 3 of them together, grouped them up, and made a triglyceride because your cells didn't need it. Now that's really smart of the insulin to do that, because the insulin and the human body is thinking, if I just tie it up in triglycerides, if I make a fat out of it, and I let that fat float around in the bloodstream for 24 to 48 hours, I bet the cell will need it by then. In other words, you may be satisfied now. I'll tell you what, I'll hold on to this in the form of triglyceride. I'll be back in a day or 2 to see if you still need it. That works very well in a hunter-gatherer environment because we have these periods of fasting. I didn't get a kill. You only got an antelope once every little while, and you ran across some berries every now and then. So we had periods of fasting, didn't we? Do we have periods of fasting in America? No. We do not die of starvation anymore. We die of overabundance of food now. It's totally flipped. You used to die of starvation. Not anymore. We die because we eat too much. So we replenish sugar into the bloodstream very often. And we do it more than 3 times a day. We do it with snacks. Do you know snacks was not a word in the 1800s? Wasn't even in the vocabulary. That word was created by food manufacturers. And now everybody has to have a snack, don't they? I gotta have a snack. How many people do you know that if they miss lunch would be angry, hangry? I didn't eat breakfast and I thought I was going to eat lunch and didn't eat lunch. There aren't many people who can go 24 plus hours without eating and not be hangry. If you can, great, you're in good metabolic health. That tells me, or tells yourself, that your insulin levels are staying very flat. They're not roller coaster. They were never meant to be a roller coaster. So this triglyceride's floating around for 24 to 48 hours and it doesn't get consumed because you just put more sugar in there and the insulin says, hey, better get some more insulin out of the islets of Langerhans because we got more sugar coming. Hell, we've still got the triglycerides we had from last week. We'll go lay them down as fat. So the body, the insulin, still got one job. What's that job? Get rid of sugar. Well, I've held the triglyceride long enough. I guess I need to get rid of it. So it will go lay it down as body fat. We call that adipose tissue. What's happened? Do we have a backlog now? Are we starting to build a backlog? Yeah. So when you do blood chemistry, your triglycerides are doing this every time you check them. It's called a backlog. And the triglycerides should be less than 100. They're up there in the 7, 8, 900 range, 1200 range. Glucose should be below 100 when fasting, but stay between 80 and 120 thereabouts. It keeps going up, got a backlog. Body weight is going up. That's type 2 diabetes, guys. What's coming along with it? Kidney disease, blindness, Alzheimer's, can't think clearly, heart disease, toes rotting off, neurons in the nerve cells quit functioning. We bump our toe and we don't know it because we can't feel the pain. We get gangrene in our toenail and we got maggots eating into it. And we don't know it because we can't see it because we're blind. We can't feel it because we can't feel. All from a backlog of too much damn sugar. Too much sugar. So that's insulin's job. What is glucagon's job? If insulin gets rid of sugar and they're contradictory, it brings on sugar. And we have a name for that, Jordan. Gluconeogenesis. So we had glycolysis, and that's happening in the cell. We had glucolytics. That's what the role of insulin is. And now we have one called gluconeogenesis. And genesis means creation. Genesis means creation. So gluco, the generation of glucose. Now, if you're eating regularly, you're not fasting, rarely do you ever go into this phase. If you never fast and you're always fed, rarely do you go into this phase. In today's environment, we get a whole lot of insulin in people and very little glucagon because food's always readily available. But let's just say you are one of those who practice intermittent fasting, or you're one of those who says, you know, I can skip lunch and get this job done. And your body says, well, you didn't eat, so we got to get sugar from somewhere. We got to get the glucose from somewhere. So the signal goes down to the islets of Langerhans to produce glucagon. Now glucagon's a hormone, and when it gets into the bloodstream, it goes by the liver and tells the liver, hey, you need to release your stored glucose. Remember, insulin stored it there last week. Glucagon says, hey, we need that. And the liver says, here you go. Here you go. Here's some glucose. And that glucose is in the form called glucagon. Glycogen. There's too many GLYs in here, isn't there? Glycogen released by glucagon in times of fasting. So if your blood sugar dips below, on the average, let's just say 80, and the body says, I need to bring that level back up above 80, glucagon's what causes that to happen. So you store glycogen in the liver, and you store glycogen in the major muscles, like your big muscles, like your thigh muscles and your buttocks. They store glucagon or glycogen. This is why if you're trying to control your diabetes, if you happen to have diabetes, the best way to reverse insulin resistance is to build muscle mass. There's nothing better for a diabetic who's trying to get out of this than build muscle mass. As we get older, we should build muscle mass. Keeping muscle mass is highly, highly, highly important to metabolism because it is a storehouse for excess sugars without storing it as fat. Okay? Luke, I look at you because I know you're into weightlifting and stuff. No carbs don't work well because you need the carbs to pull the proteins in and everything else. It just doesn't work well. It can work, but it doesn't work as well. It's a storehouse. And so storing glycogen is a lot better than storing adipose tissue. It's a healthier way to store the excess energy. Okay. We have this fine balance between hypoglycemia and hyperglycemia. We can put numbers to it if we want to. Your blood glucose should stay between, and it's easy to remember because it's kind of the opposite of the blood pressure. It should stay between 80 to 120. Will it go above that? Sure it will. But your body will do what? Pull it right back down. Will it ever go below 80? Sure it will. But your body will do what? Pull it right back up. That's about a 1 teaspoon amount of sugar in your bloodstream difference. How fine a balance do you have in your bloodstream between too much sugar and not enough sugar? About 1 teaspoon diluted across your entire blood volume. Any more or any less than that is deadly. Any more or any less than that is deadly. The pancreas has a huge role in that. What else has a huge role in it? What other organ? The liver. That thing we abuse every Friday night. That liver has a huge role in that. Do you see alcoholics and diabetics often being in the same person? Why? The liver is taxed to death, literally. The liver says, what the hell? The liver stores so much. You ever heard of empty calories? That's what we call alcohol, right? Have you ever looked at a can of beer and said, it's got 110 calories, but only 3 grams of carb? Now, the caloric value of 1 carb is 4. 4 calories in a gram of carb. 4 calories in a gram of protein. 9 calories in a gram of fat. So what's the most dense fuel source? Fat. But you only get 4 calories out of 1 gram of carb. This beer has 3 carbs. Do the math. 3 times 4 should be 12, right? But the beer has 110 calories in it, according to the can. How did you get 110 calories out of 3 grams of carbs? Anyone want to guess?
Sugar? The unknown substances they put.
They're empty calories. They have no nutritional value. What does the pancreas do when it sees those empty calories coming? It tries to get rid of them. And what does it use to get rid of these things? But there's no nutritional value to them. So your body can burn them and get nothing out of them other than fat. Other than fat. Your insulin will convert those empty calories into fat. And it tries to get rid of them. So where does it try to put them? It tries to store them as glycogens. Where is it going to put those? It's going to put those in the liver and the major muscles. So we end up with fatty liver disease. The liver, which is, if you've ever looked at a liver, just imagine calf liver or chicken liver or something like that. It's just a real dense tissue. It doesn't have any fat in it. If you want to talk about lean, it's lean. Not in these patients. We get big deposits of fat. What if you try to store all this glycogen in the muscles in excess? What happens to all of that from all the alcohol? Well, you get fat in your muscles. Well, fat's supposed to be on the layer, on the outside, but you get fat in the muscle. What do we like to do to our steers in a feedlot? What do we do to our steers in a feedlot? Because all of you, almost all of you, I'm going to assume almost all of you, there'll be a few exceptions, like to eat beef. Everybody enjoys a good steak. How do we like our steaks? Marbled. That's what makes it choice, right? And prime and all those USDA markings. We like our steaks to be marbled. What's inside that muscle? Fat. How do we get the fat in the muscle? Well, it's not from grain finishing. It's not from grass finishing. It's from grain finishing. What are we feeding these steers in the feedlot? Grains. What else do we do with grains? Make beer, alcohol. Do you know that the steer in the feedlot has to take antibiotics? Because if it doesn't take the antibiotics, it will die before it reaches its maturation, which is 18 months to 2 years. If they live longer than that, they would die of fatty liver disease. They'd have liver abscesses. Yeah, nice. Nice, isn't it? So you want grass-finished beef, if possible, not grain-finished, because of this reason right here. Well, we're doing the same thing to our body when we eat all that. We put all this fat in our muscle. We marble our own muscles. It's not a healthy environment, is it? This is why we make all these calls to these people. So we can go two ways with this. And to be a diabetic means you have problems regulating the sugar. And most people get in trouble long term is when the sugar gets too high. It starts climbing. It's consistently staying too high. Why is it too high? Well, one of two reasons. You don't have any insulin, or your body doesn't like the insulin. The result is the cells don't get the glucose. And it continues to climb and climb and climb and climb. We get so far behind the curve that we have to intervene with this. So which one do y'all want to go down first? Too low or too high?
Low.
Let's go too low. Let's go too low. Because you asked for it. Too low blood sugar. I must preface this by saying too low of sugar can happen to people who are not diabetics. Okay, we're on diabetic emergencies, but this is where we talk about it. Gus, can you tell me one person from yesterday whose sugar can get too low, in other words, be hypoglycemic? Huh?
Malnourished.
Okay, malnourishment. Let me change that because that has a different meaning. Can we say starvation? Can we do that? I don't think it's any different than fasting. One may be intentional, one may be non-intentional. Reduced caloric intake. If you're otherwise healthy and have resilience, you can tolerate this for a long time, can't you? Your body will kick out glycogen, your body will start digesting its fats. You can do this for a while, can't you? If you're otherwise healthy. If you don't have glycogen stores, if you don't have body fat, you will end up in this position a lot sooner. Are alcoholics malnourished starvation people? And I say that because that's a broad category that we'll deal with a lot. There's a lot of alcoholics or alcoholism, and a lot of alcoholics, you're full-blown guys and girls, they'd rather drink than eat, and they're eating empty calories, blah, blah, blah. Yes, the answer is yes. Sugar gets too low. What's the body normally do? Secrete glucagon. What's the glucagon normally tell the body to do? Release the stores. Release the storehouse. That'll get us by once. That'll get us by once. Continuing to starve or fast, we don't have any stores to go to, our blood sugar goes dangerously low, and the body runs out of energy. You are literally out of gas. At this point, it's deadly. Good alcohol to drink? No. The answer is simply no.
Not even wine?
The answer is simply no. There's no nutritional value. And even if you did a mixer, you're just getting a lot of sugars to go with it. Unfortunately. But yeah, no. It's deadly. It's too low. What do you think some of the signs and symptoms of this might be? I mean, this you did choose the easy one. What? Stroke-like symptoms, which are what?
Altered status.
Okay, yeah, I love that one. Let's go with that one first. Altered mental status. All the way down to what? You on the AVPU scale, unresponsive. But it could be very early, just hangry. I think most of us have probably been there. That's a take off the Snickers commercial. When you're hungry, you're not yourself. Eat a Snicker. No, probably not, but I mean, if you need a quick jolt, I guess it'd be okay. Eat a Snicker on your way to a steak, I guess.
They use a lot of chocolate to combat a lot of blueberry fighters.
Because it's quick. It's quick. Altered mental status, though, can be as subtle as you're just irritated. Why do you get mad when your sugar gets low? Well, your brain's not happy. It's running out of energy. When your car runs out of gas, it starts spittering and sputtering, doesn't it? But it's still going, but something's not right. Continued, without intervention, things go from bad to worse. And so they are shaky, irritable. Do they have a headache? You ever get a headache when you run out of fuel? Get a headache? Do you get sweaty? Kind of like diaphoretic? Yeah. Cool, clammy?
You get droopiness?
Like tired? Fatigue?
Or like stroke kind of stuff.
Yeah, sure. Your muscles will fatigue. So fatigue is both not only in the mental brain, but the muscles will fatigue. Weakness is another word.
Do they get polygypsia?
Not yet. You're on the wrong side, man.
Seizures?
Huh?
Seizures?
Yeah, they could have seizures. But what else goes along with seizures? I'm gonna make a little asterisk by that. Seizures could cause that. because we check blood sugar on all altered mental status and seizure patients. What else happens when the sugar runs out? Oh, yeah. I'm just going to abbreviate that NV, nausea and vomiting.
They die.
Death? I like it. Yeah, sure. All right.
Their respiratory system.
Let's just go death. Yeah. It is deadly. It is deadly. With no storehouse,
Cardiac arrhythmia.
could have some cardiac issues because that has cardiac cells have twice the number of mitochondria that your skeletal muscle cells have. I'm not saying it can't happen, but it doesn't show up as a sign and symptom yet.
That cause your heart rate to drop like drastically?
It could go really high or really low, yes. That's why I put such a broad category. Rhythm disturbances, cardiac issues, arrhythmias, irregular pulse. Well, what's the fix? So what's the TX? In no certain order, glucagon. Now, let's pause on that a second.
Oral. Even if they're not breathing.
Let's pause on that a second. Glucagon is a hormone secreted by the alpha cells of the islets of Langerhans. So how in the heck is that a treatment? Well, modern medicine has synthesized glucagon, and we can give our hypoglycemic patient glucagon through an injection. Just like you can take testosterone, estrogen, thyroid hormones. This is a hormone. We have the ability to give that via injection. BLS doesn't do it, but paramedics do carry it in their drug kit. And a paramedic would give a patient suffering from hypoglycemia glucagon. It will only work if what? It only works, though, if they have stored glycogen. If they've already exhausted the storehouse, it's not going to work. Huh? Okay, so another treatment is D50. I'm going to change that to IV glucose. Now he says D50, there's also D25, there's D10, there's D5. These are just concentrations of the solution. When you say something is 50% or D50, it's 50% dextrose and 50% water. Dextrose being a form of sugar. D25, 25% dextrose, 75% water. D10, it's a 90-10. D5, 95-10. Let me say this about these high concentrations of D50. They are necrotic. Necrotic. If a paramedic gives D50 into someone's vein and the vein ruptures, also known as blows, the vein blows open, or if it infiltrates, if you want to get very specific, and the D50 doesn't stay in the vein and it goes out into the tissues, that tissue will die and slough off and rot. It'll just rot and slough off. Get infected. That's probably the last thing a diabetic needs is an infection. If they're having a bleed in the brain and that high dose gets up there and the brain is exposed to high doses of D50, the brain cells will die. It is necrotic, means if it touches a cell, it will kill it. Because if you want to know why, it has high osmotic pressure. It kills the cells by dehydrating them. Because water follows salt, water also follows sugar. You ever been to a cafe and you wanted that really sweet tea and you're supposed to pour it out of a container but it wouldn't come out because it's clumped? That's because it absorbed water from the atmosphere. That's an easy way of saying that sugar has high osmotic pressure, so much so it pulls water out of the atmosphere. So it pulls water out of the cells and the cells shrink and die. They dehydrate. It dehydrates the cells. So we give it in. A lot of people are now giving it in less concentrated forms, but you don't get much energy out of D50. If I give somebody D50 as a paramedic, if you're an EMT and you're sitting there next to him, and you called the paramedic in there because the patient was unconscious and you couldn't give anything by mouth, so you call the paramedic and he or she pushed D50, they are giving in that one injection 25 grams of carb. How many calories is that? See if you remember what I just said.
100?
100. Because 25 times 4 is 100. 100 calories. That may be enough to wake them up, but it's not the fix. Because how long will 100 calories last? Especially someone that's in a deficit. Not very long. So anytime you see this, you must ensure that this patient's going to take in more calories, some method, whether they go to the hospital and get a meal or get a meal at the house. The less concentrated, obviously the less calories you're getting. So you may have to repeat these doses. That's one treatment, but neither one of these yet are EMT style. Not that they're wrong, they're just not EMT style. These are ALS treatments. What about the BLS treatment? Oral glucose, I'll just say it simply. Oral glucose. And to get oral glucose in the body, the patient must be conscious and able to swallow and protect their airway. That's it. That's all you can do for them. I don't care which form of glucose you give them, whether it's your commercially prepared little tube, or you go to their candy jar and get a Snicker, or you give them a bite of peanut butter, or you have them drink a Dr. Pepper like I did with that kid. Usually the liquids are super fast at waking them up because we don't even have to digest them. They just suck right over. That's why drinking juice is routinely so bad for you, because your body just does not. That is like an insane amount of sugar coming down the system so quick. You had a question.
My friend was diabetic, and he had his little bag that he would carry with him. He was type 1, and if he ever like passed out, he showed all his like friends and the teachers how to use it. It was, I don't know what it's called. I don't even know what it is. I'm kind of curious. But it was a vial and a big syringe. And you drew out like the saline out of the one vial.
Yeah, glucagon. This is it. Glucagon has to be what we call reconstituted. So it's a powder in the vial, and you got a syringe full of water. I'll bring one in at break if I can find it. They moved a bunch of stuff around. You have to push it into the powder and shake it up until the powder dissolves. In other words, reconstitute it and then inject it into the muscle.
I didn't know if it was glucagon or what it would be.
Yep, it's glucagon.
Did you give them epi? Like a small dose of epi?
That would only make things worse. That'd be like giving them crack cocaine without any energy. Because epi's going to increase thermogenesis. It's going to hyper everything. So it's actually going to deplete the stores even faster.
What else could you give besides glucose?
Glucose and glucagon's it. That's it.
Well, like, so if they are like passed out or they're
Okay.
hypoglycemic, we're on scene, and would it be like, what if a Dr. Pepper's quicker than getting oral glucose?
Sure. And probably much more tolerable.
Yeah, that's what I was about to say.
There's nothing that says you got to use the fancy little tube that's in your go bag. Orange juice, apple juice, grape juice, pear juice, peanut butter. Do y'all know 2 slices of bread, and I don't care what kind of bread it is, will raise your glucose levels more than drinking a Coca-Cola or a Dr. Pepper? You can sit down with a Coca-Cola and you can sit down with 2 slices of bread, and the 2 slices of bread will raise your glucose more.
Why is that?
Because there's more damn sugars and carbs in that 2 slices of bread than there are in that Coca-Cola.
Really?
Yeah.
I'm pretty sure there's like, it's either 12 or 15 carbs in a slice of bread, and there's like 43 in a Coke.
Well, that's 24, but I'm talking about spiking your blood sugar.
Okay.
Yeah.
Diabetic finger sticks in prison, what we used to call them finger sticks there,
Uh-huh.
diabetic, whatever. They actually put peanut butter as one of their replacement on their meals. When they buy it,
Two.
crashing out.
Yeah, yeah. Peanut butter works very well too as a replacement because there's a lot of sugar in peanut butter. It in itself is a carb, but then they add the sugar to it to make you like it even better. Sugar is easily obtained. Sugar is easily obtained. Now, it's got to go either through the mouth or into the vein. It doesn't absorb under the armpit or through the nose, okay? So anybody that's telling you that is full of it. They need to do their homework. BLS care for low blood sugar, got to get the sugar in them. If you can't because they're unconscious, ALS is an absolute. Is it deadly? Yes, it's deadly. The patient could die because they're simply out of fuel. Let's add to our list of causes, okay? So we kind of left that, even though we said it. That's true. That's one of the causes. You just stop eating for whatever reason. Give me another reason that people get into a hypoglycemic state. Jonah, you kind of touched on it. Diabetics who take meds. So let me call that mismanaged diabetes. And in this way, the mismanagement is they've either taken too much insulin relative to their caloric intake or too much oral hypoglycemic agents. That's what your type 2 diabetics take. They take the metformins and the diabinese and things like that. Medications that make your cells more responsive to their own insulin. If they take too much insulin or too many of those pills in relation to how much they've consumed, well, they could get themselves into too low a blood sugar. You'll find this a lot in patients who are new to the scene. You know, like they just been diagnosed with diabetes and they've got their insulin at home or they got their pills and they just haven't quite figured out how much insulin to take. And it's a complicated, it's called a sliding scale. You see how many calories you take and then you give yourself the appropriate amount of insulin. And insulin is a hormone, so it's going to be measured in what we call units. All hormones are given as medicines in the term units. So that's why you'll say here, I took 20 units of Humulin R or something like that. There are all forms of insulins now. Original insulin was swine insulin. So we would pull it from a pig, swine, and we would give it to our diabetics. And that's how they got their insulin. They would inject swine insulin into them. And that worked very well for a really long period of time, but the Jewish people who happen to be diabetic had an issue because they can't take pork products. So that's set off the synthetic insulin business. So chemists got together and now they have synthetic insulins. And there are many, many types. And sometimes your body has a hard time adjusting to that one, or it'll get tired of that when you have to switch to another one. And anytime you get to switching these things up, you fall into, I spelled mayonnaise wrong, you fall into an issue where it may work a little better than you thought it did, and it would drive your blood sugar down. That's why your friend had the go bag that had sugar in it. I don't know if any of you have paid attention or if it's even still there. It is in Oklahoma. One of the restrictions on a driver's license is food must be within reach. Is that a Texas thing too? So if you're diagnosed as a diabetic and you get your driver's license in Oklahoma, there's a restriction on there. And the restriction says food must be within reach. So if you're driving a car and you have low blood sugar, you ought to be able to reach over and get you a Snickers and keep driving, because your blood sugar is bottoming out. Do you want that on the road with you? No. So mismanaged diabetes. Too much insulin, not enough fuel. Too much of their pills, not enough fuel. It's going to drive it down. Questions on that? It's pretty easy, isn't it? But we have a real high suspect in any altered mental status. You don't have to be a diabetic to get in this position. So now we're going to do hyperglycemia, and you are a diabetic there. At least temporarily.
When diabetic experiences breakfast episodes, they experience hyper or hypo?
Oh, hyper.
They go hyper and then crash out.
Yeah, the only reason we talk about hypo in this diabetic lecture is because mismanagement drives you there. We just learned yesterday that hypo can happen in a seizure, and that's not diabetic. It can happen to the person who wants to lose weight immediately. That's not a diabetic. It can happen to someone who is abused and locked in a room and not fed. It can happen to an alcoholic who doesn't eat, just drinks because they're getting empty calories. There's all these reasons. People can have an overactive pancreas for whatever reason. They're not diabetic. So to be diabetic, let's talk about the disease first. The disease of diabetes. There are a couple of different ones. There's diabetes insipidus, diabetes mellitus. Let's don't go off in the weeds on all the different those different things. Let's just simply say diabetes means an inability to regulate blood sugar. An inability to regulate blood glucose levels. There are two ways that happens. And we will just divide this in type 1 versus type 2. I don't like these terms. I do not like these terms. You will hear people call this juvenile onset. And this adult onset. I do not like those terms. They are misleading.
Can they both be genetic? Because I thought type 1 meant genetic, type 2 meant...
That's where they get the juvenile. You're kind of born with it. Type 2 adult onset. I wouldn't say this one's got much genetic component. I just wouldn't say this. Can I speak to that a minute? Can I speak to that a minute? To all of you? You live in an area that is real close to what we now call, Oklahoma used to be what before it was Oklahoma? Indian Territory. Where did the Indians come from? They came from the southeast. They were relocated. And so the federal government, the U.S. government made a deal with the Indian tribes. If you move yourself to Oklahoma and let us have Georgia and Florida and South Carolina and North Carolina, let us have this and we'll give you something out there. So they relocated the Indians, Trail of Tears, you all aware of that? 5 civilized tribes populate Oklahoma. When European settlers hit the Americas, they brought with them something that the Native Americans didn't have, and that's the potato. There were no potatoes in this continent. But the Europeans loved the potatoes, and that was a great way for them to make the voyage. They could store potatoes for a long period of time. It was a main staple of their diet. Now, American Indians, Native Americans, were not evolved, they did not evolve to process the potato. Their GI tract, their metabolism, a potato just wreaks havoc on them. They also didn't have alcohol. Now they may have had peyote, but they didn't have alcohol.
They had fire water too.
So the Europeans brought alcohol and potatoes. Well, you give alcohol and potato to a Native American, that's like crack cocaine, man. It's like, so a real high demographic of alcoholics are Native American. A real high demographic of diabetes is Native American. So profiling's wrong, but profiling's accurate. If I've got an altered mental status and I can tell by the look of a patient that they probably have a lot of Native American ancestry, I'm at real high alert for diabetic issues, blood sugar issues, and alcoholism. It's just the way it is. Now, we gave something back. We, because I'm a member of the Choctaw tribe, I can say we gave something back. They didn't have corn, and we gave them corn. Now, the corn we gave them wasn't like the corn we have today. It wasn't that super sweet candy corn or G90 that these farmers grow. It was field corn. It was maize. It was hominy. Anybody ever had hominy? Nobody in here has had hominy. You've had hominy? You hate it. Do you hate it? Who else has had hominy? I got two. We may have to just open a can of hominy tomorrow, okay? And let you taste it. It's corn. Why do you hate it? It tastes like cardboard, doesn't it? It tastes like paper. It tastes like starch. It tastes like you shuck the corn and you're eating the shuck and threw the corn away. Huh?
Like deer corn?
It's worse than deer corn. It has really low sugar, even though it's still got a lot of sugar in it. But compared to what you eat out of the little green giant can, or when you eat corn corn on the cob, you're not eating that. Hominy's gross.
That's real corn?
But it's corn. It's more native. And there really isn't even a corn plant. That's something man has genetically crossbred to even get to corn. Johnson grass on the side of the road is about the closest native thing to corn. Corn is just grass, and you're eating the seed of that grass. Get back to this. When you talk about genetics, is there some genetic component there? I would say there's more of an evolutionary component there. But look what happens. Well, I'm going to use my own family as an example because most of them are dead, and the ones that are alive don't care. There is a high history of diabetes in my family. On my mother's side, that's where the Native American stuff comes from. So what do the doctors say about me? Because my same doctor treats my mother, my father, and he treated my grandfather. So he knows the family history. So he tells me I am what? Genetically predisposed to having diabetes. So I have to keep an eye on my blood sugar. My brother, same parents, full brother, he's a diabetic. He's a type 2 diabetic. He takes metformin. I don't. Well, how'd that happen? Well, he got the bad side of the genetics. No. What happens in these genetic blame games? He grew up in the same house I grew up in. My diet is so different than my mother's. I had to consciously pull out of that, or I'd be there too. There was a time about 15, 20 years ago, I'd go get my blood checked and I was pre-diabetic. My mother grew up in one house, her father's house, who was a diabetic. And I can now reflect back upon what they eat as their diet and stuff. It wasn't the genetics, it was the diet, it was the lifestyle. You probably live like your parents live, and they probably live like their grandparents live, and they probably have the same habits. One of the favorite routines I had as a younger person was a bowl of cereal each night before bed, because that's what I had at home. That was my bedtime snack. A lot of people eat a bowl of cereal as soon as they wake up. Start your day with a healthy breakfast, Kellogg's, cornflakes, and There's no cereal good for you. So don't, just get rid of that bull crap.
What about just dried oats?
There's no cereal good for you. Just stop with the cereal. It's bad. It's really, really bad. It's very expensive for what you get too. That's ridiculous. I remember raising my son. It was kind of a little thing my son and I had. We would have a bowl of cereal before bed, and he got addicted to it himself. So what I'm saying is, we blame a lot on genetics when it's really just a lifestyle, and it looks like genetics. Well, your mother had it. Well, I'm eating the same thing she's eating. So be careful with that. Since you brought it up, is there a genetic component? Sure, but I don't think it's a defect. I think it's just an inability to metabolize certain things. Here's what I want you to call this: insulin-dependent diabetes mellitus. Non-insulin dependent diabetes mellitus. So when you get up to a patient and they say, I have diabetes, I only want you to ask one question. Do you take insulin? That's a yes/no answer. If they say yes, then they are an IDDM. You could just simply say they're insulin dependent. They are injecting themselves with insulin. If they say no, and they're diabetic, they are non-insulin dependent diabetic. Insulin dependent diabetes mellitus, non-insulin dependent diabetes mellitus. If they say no to taking insulin, now they're over here in this side of the flow chart. Your next question is, how do you manage your diabetes? They're going to say one of two things. Oral hypoglycemic agents, that's just a class of drugs. This is metformin. Something like metformin. It's a drug that makes your body do one or two things. Either be more responsive to the insulin that it does have, or make your islets of Langerhans make more insulin. Or they control it through diet. And that would be the healthier option, obviously. That's how they keep their blood sugar in check. They either take insulin, they take an oral hypoglycemic agent, or they control it through diet. I would venture to say that if they're controlling it through diet, they are not diabetic. Okay? If you can fix your blood sugar issues by food choices, you're not a diabetic. I think there's a flip side of that coin. I think if you are a diabetic that can be controlled by diet, but you choose not to, I think your disease is one of lifestyle, don't you? What is the fastest growing comorbidity factor in this country? Type 2 diabetes. If you were to graph it, it looks like this. It's continually getting higher and higher and higher and higher. You will encounter so many people who are type 2 diabetics. How do they control it? I control it through medication. Okay. The purpose of that medication was for someone who had the right diet anyway, but the blood sugar still wouldn't come down. But we got lazy and just started taking, we'll eat our sugars and take the pill. My mother's a great example. Mom, you can't eat the apple pie I made. I'll take another pill. I'm not going to turn down apple pie. Okay. Okay. So is my mother or my brother diabetics, or is it lifestyle choice? It's lifestyle choice. If there's a Dr. Pepper can in the trash, it's lifestyle choice. Time is it? Let me get this one thing out here and then we'll go to break. So we know how it gets there. What's it do to the body? So high blood sugar over time, extended period of time, cells start to starve because the sugar's not getting in the cells, staying in the blood, so the cells start to starve. They get hungry. They signal the brain, we're hungry. And the organism goes and eats some more, but it doesn't do any good, does it? So high blood sugar over time leads to an increase in something called ketogenesis. Ketogenesis. Ketogenesis results from the body burning fat for fuel. The body's burning fat for fuel. It says, if I can't have glucose to eat, give me something to eat. And we start breaking down, the human starts breaking down its stored fat. When we bring fat back out of storage, and we metabolize that fat, we create, this leads to an increase in something called ketone production. Ketone production is what the body is now eating. It is eating ketones. Actually, a very good fuel source. An otherwise healthy individual can drive themselves into that. If you want to lose weight, if you want to drop the next 20 to 30 pounds and get it off in a hurry, go into ketosis. That means you're not eating any carbs. Your carb intake is less than 20 a day. And for some people, it may have to get as low as 10 or 15 a day, or 0. If you eat no carbs, after about 2 or 3 days, you'll go into ketosis. Your body starts eating its own fat. And since that's its only fuel source, it drops rapidly.
Is that a healthy way of doing this?
Yeah. Yeah. If not the healthiest way to do it. Now, in that 2 to 3 day switchover, your brain's going to get really pissy because it's withdrawing from sugar and you're going to have withdrawal symptoms. But before I digress there, let's go ahead with the diabetic. In the diabetic patient, we have an increase in ketone production. Now, there's a byproduct to this. Let me drop down here. Ketones are an acid. Ketones are an acid. Now, back to your question, is it a healthy way to lose weight? You got to take this into account and keep this normal. But if a person gets in here accidentally because they're diabetic, it's a different story. There's purposeful ketosis, there's diabetic ketosis. You with me? The diabetic gets into this without trying. These are an acid. So what are they doing to the blood pH? Blood pH. One more time. Dropping it. So instead of 7.35, 7.45, we're below 7.35. Blood becomes acidic. So we get a decrease in pH. What do we know about acid-base imbalance? When the body gets the pH out of whack, it starts trying to, the word is, fix it, compensate for it, return it to homeostasis, try. So we go into compensatory mechanisms. So one of the first things we will do, and that equals an increase in exhaled CO2. So the body's going to start blowing off a lot of CO2 to get rid of the extra acid, right? Because CO2 in the bloodstream binds with the H2O to create H2CO3, carbonic acid and stuff like that. We got to get rid of the CO2. So an increase in exhaled CO2 equals something we call Kussmaul's respirations. Let me write that because you probably have never seen that before. Kussmaul's, that's Kuss. Maul, M-U-A-L, like the Rottweiler does to you. Kussmaul's, that's apostrophe S, respirations. And they are basically increased rate, increased depth. They're hyperventilating. When you find this patient, oftentimes their respirations have increased. They're not pursed lip breathing, but they're like, and they stink. They stink. Ketones smell like acetone. And as a matter of fact, they are really close chemically.
So is this ketoacidosis?
Getting there. Getting there. If we compensate, it's not acidosis. We fail to compensate because either we get too much production or we exhaust our compensatory mechanisms. Then we go into, ultimately right down here, we're going to have DKA. Acetone breath. Your book says acetone breath. When you walk in the room, you're going to smell the breath. It's going to smell like rotten bananas. Some people describe it as juicy fruit. Nail polish remover. It smells identical to nail polish remover. I have been in homes and bedrooms of patients where I literally thought someone spilled a bottle of nail polish remover. That's how strong the acetones were in the room. Eye-watering strong. Acetone breath. And that's in quotations. It's really ketonic breath. If you'll know, if you ever try to go into ketosis to lose weight purposely, your friends will tell you your breath stinks, if they're any friend at all. So you know when you go into ketosis because your breath will stink. It doesn't really stink, it just smells odd. Acetone breath. What else will the body try to do to compensate for the acid? Remember this from our earlier lectures? We got too much acid in the blood. We up our breathing. We blow off the CO2. There's another way to balance the blood, isn't there? Through the kidneys. Renal buffering. Remember renal buffering? And so the body will begin to dump urine. And what it's doing in dumping urine, it's dumping urea. It's dumping urea, which is an acid in itself. Any of you drive a truck that needs DPF fluid? Exhaust fluid? Diesel trucks? Know what I'm talking about? Hunter tractors maybe? They require DPF. Don't spill it on the paint, right? Because it'll eat the paint. That's the same thing a diabetic's peeing out in their urine. Urea. It's a form of nitrogen. It's a protein base. It's real good for the grass. If a diabetic pees outside, it'll fertilize the grass. But it's hell on the kidneys. It's working the kidneys really, really hard.
So you said Kussmaul's regulates?
Kussmaul's respirations is trying to get rid of that CO2. The kidneys working overtime dumping urea is trying to get rid of the hydrogen ion through an ammonia that we call urea. And Jordan, we have a name for this increase in urine dump. It is called poly means many, urea. Polyuria. This patient pees a lot. One of their symptoms are they're peeing a lot. So if you ask about their sample history, they pee a lot. More than normal. And because we're peeing more than normal, we're starting to dehydrate the organism. And so increased urine production leads to an increase in thirst. And that has a name, polydipsia. Polydipsia. And you can remember that as like if you were to take the thing and dip out a drink of water out of a pail or something. Polydipsia. Increased thirst. Because they're dehydrated. Why are they dehydrated? because they're peeing out too much. Are the cells hungry? So they also have an increase in hunger. We have a name for that. Polyphagia. That's known as the 3 P's of diabetes mellitus. So if anyone ever asks you what are the 3 P's of diabetes mellitus, it's the telltale signs. Polyuria, polydipsia, polyphagia. Increased hunger, increased thirst, increased urination. And that's all trying to keep the blood pH in balance. And depending on the individual, they may do this for some period of time.
It's the 3 P's of what?
Diabetes mellitus. All this has the telltale sign of increased blood sugar. Because they're eating, they can't get rid of the sugar. So the body starts digesting its own fats, which sets off this cycle of fat metabolism, with the byproduct being a lot of acid. And that byproduct is what gets people in trouble. Once they cross a threshold, and Leighton, I think it was you, once they cross a threshold to where they can no longer fix the blood pH and they start decompensating, when they decompensate, for the drop in pH, that will lead to a condition called diabetic ketoacidosis, and we know that as DKA. Diabetic ketoacidosis, DKA. Let me say this.
So how do you know when they're starting to go into acidosis rather than just having a high blood sugar?
Great question. You read my mind, because I was just about, that's why I put the word rare. True DKA is rare. And the question on the floor is, how do you know if someone is in DKA or not? I believe that's your question, isn't it? You're going to see all those symptoms, but that does not mean you're in DKA. That just means you're trying to compensate for acidosis. So the true reading would be once you get to the hospital and they draw your blood and the blood pH is low. You can have all the above and your blood pH be okay. You got to have an ABG to get a true diagnosis of DKA. Now, let me add to that a little bit. I can guess in the field. If your hair is crumbly, if the patient's hair is so dry it's brittle and breaks when I touch it, that's part of my assessment. When I look in their mouth and they have a furrowed tongue, meaning they're so dehydrated the tongue has started to curl up and it's got this furrow down the middle of it. A lot of people don't understand what the term furrow means. A furrow is a ditch in the ground that a plow leaves if you're plowing the ground. Furrow. So you got a ditch down the middle of your tongue because it's so dry it starts curling up. When your eyes have sunken back in your head, when you can't blink because your eyes are so dry that the eyelids stick to the eyeball, when your skin is so dry that when I pinch it up, it just stays. That's called poor skin turgor, Turgor. When the room reeks of acetone, I'm pretty sure you're in DKA. But I can't confirm it until I get the blood test, okay? So there are various, it's on a spectrum, if you will, or a sliding scale or whatever. I mean, you're getting toward DKA. Who gets into DKA? I don't know. It depends on how well they compensate and how long they've been in this. What other question do you have? That's a lot of information, guys. That's a lot of information. Well, when I come back from break, we haven't seen anything yet. Yeah, you're going to retract that statement in a minute. We come back from a break, I'm going to talk about non-ketonic hyperosmotic.
There's a big word.
That was only part of it. If they stay in this to the point to where they are now in what's called a coma, when the AFPU scale is went unresponsive, we call it diabetic coma. And that's probably a real good indicator that they are in DKA because they're comatose. That means the brain is so dysfunctional.
Are they still like responsive?
No, not very much. Sometimes they go completely out. They're in a really, really toxic environment. This takes a long time to develop. A person doesn't skip an insulin. A person doesn't, skip his insulin and get into this within the next hour. This is a long process. Therefore, to add to that, it's not life-threatening here. But as time goes and we go deeper and deeper and deeper, it's becoming life-threatening. Whereas the hypo, it's life-threatening right then, within minutes to hours. This is life-threatening over days, weeks, months, maybe even months. You are often the EMS person is often the one who will discover this. They may not even know they're diabetic until you get a hold of them and start doing some things. Is there damage being done? What if you just hang out in here for a few years? You're up here in this borderline. You're really not going into ketosis. You may dabble in it, and then you may get some kind of back and forth. But your blood sugar level is consistently high over a long period of time. It hasn't manifested into full-blown. It's kind of hidden. You're tolerating this. You're kind of teetering up here. Is there damage being done? Yeah, at the capillary level. Keep thinking about the capillaries here. You start clogging up the capillaries in the eye. Blindness is a major thing. Kidneys. You're clogging up the kidneys because they have real fine capillaries. Extremities. Heart. Because it's all hanging out back there. Remember the board prior to that. Type 1 or type 2 get you here. One question and we'll go on break. It'll be exactly 10:30. If you had to have one of the diseases, or if you had to have one of the forms of diabetes, type 1 or type 2, those were your only two options, which one would you pick?
Two.
Why do you want, what was your answer, 1?
2.
2? Why do you want type 2?
Because I can get myself out of there. I can diet.
Okay.
Already.
Well, if I can get myself out of it, if I had to be, like there was no reversal.
Let's say you're 50 or 60 years old. Which one would you choose?
Let me say this, for most people, and it's to your point and yours as well, type 1's easier to manage.
There's no insulin.
I just take the insulin. Type 2 diabetes, your cells get sick of insulin. They don't want it. And once you train the cells to not want insulin, you better hope you catch it early. You better hope you don't go into your 60s with it and it started in your 20s, because you may never revert those cells back. I'm with you. I think you can, but there's a point of no return. Type 1's easier to manage. You balance what you take in with the amount of insulin you take. If you create the type 2 in your body, boy, it's hard to reverse, because 1, you got lifestyle changes you may not want. Number 2, then you got to wake the cells back up to respond. And you might have burned out the islets of Langerhans.
They're both death sentences though, right?
Yeah. Well, no. Well-managed type 1, you live a normal life. So we got to talk about insulin pumps when we come back. We got to talk about insulin as an injection when we come back. And we got to talk about non-ketonic hyperosmotic diabetic hyperosmotic diabetic ketoacidosis. All right, y'all take a break.